Hello, my name is Dr. Dave Webster, and this is part of my ongoing video blog series about the travesty of lack of access to PET-CT in our so-called evidence-based and patients' healthcare, patients' first healthcare system. And this particular video is about why does Cancer Care Ontario want our cancer patients to have unnecessary stress, suffering, and harm. In case example, you'll see will lead me to say that if you are diagnosed with a lung nodule, you should leave Ontario immediately. Now, this is the senior executive again from Cancer Care Ontario. Dr. Doolin Dobranowski is the provincial head of Cancer Imaging Program for Cancer Care Ontario. The actions of Cancer Care Ontario have officially been condemned as unethical and bordering on immoral. However, dare challenge them on these issues, and they threaten to take away your license to practice medicine. So let's just have a very quick review of what a PET-CT is. You're going to be more familiar with the CT. So a CT gives us exquisite pictures of anatomy, but unfortunately it has almost zero ability to determine whether the mass they identify is cancer, an infection, or possibly just scar tissue. Big difference for the patient. Now, here's an example, a 67-year-old female with a history of breast cancer and smoking, and there's an incidental finding of a right lung nodule. And here we can see it right here, this little nodule in her right lung apex. Now, it would have about a 30 to 40% chance of being malignant, but the PET scan can directly image functional metabolism of cells in these tissues. Typically, we use a form of radioactive glucose. Why? Because all cells can metabolize glucose, but it turns out the cancer cells must use glucose, and they do so very inefficiently, and so cancers tend to stand out against the other tissues. So it's performed typically as a PET, and we fuse it with a low-dose CT scan. Now, here's the scan again. The patient has the PET scan, and as you can see, there's barely any glucose in that it's below normal tissues of muscle and so on around here. What that tells us is this now has about a 5% chance of being cancer, and it can be followed by serial PET-CT scans, unless you live in Ontario, in which case it would be followed by CT scans. But it actually could turn out to be a cancer, but also this low uptake tells us this will not be an aggressive cancer, and the patient should do fine, even though there is a delay. On the other hand, here's a nodule here, again about a 30 to 40% chance of being malignant. Here's the uptake, on very high uptake. Now it's got a greater than 90% chance of cancer, but it is only sugar, remember. It could be other things, and so, but we definitely tells us we need to get a tissue sample now. Now, here's a case example of a 60-year-old female who has a lung nodule identified on a CT scan, and she happens to live in Ontario. So here's her first scan. This is September 2017, and keep track of the dates here. She has a follow-up scan because she lives in Ontario in December 2017. Not much of a delay. Now we're all the way around to a year later, September 2018, and here is the report. Slowly growing spiculated nodule in the anterior aspect of the right upper lobe is described above. Its appearance is considered suspicious for a small bronchogenic carcinoma. So the patient gets the PET-CT finally in 2018, 13 months later. It does show significant uptake. They do need tissue. Now, as you can see, we now have a 95% chance of being cancer. Turns out they tried the biopsy, but her lung collapses and she needs a chest tube and is admitted to hospital. However, given high FDG uptake pattern and the slow growth, this definitely is concerning, and so now the surgeon will likely just proceed directly to treatment and removal of that nodule rather than attempt another CT-guided biopsy. But what if that patient happened to live in Quebec or Paraguay for that matter? Then same situation. She would have immediately had a PET-CT scan. It would have made clear that we needed tissue, so therefore they would have gotten the tissue. And if it turned out that it would have been a cancer, as little as maybe 6 to 8 weeks after originally finding that nodule, she could have been on appropriate treatment. But this patient has the misfortune of living in Patients First Ontario. Now, how would you feel if you were this patient or someone like you having to wait now, worry and anxious about your next CT scan? What's happening? Is it growing? Do I have cancer growing in my body? A similar patient said to her surgeon, "My life is on hold. I can't sleep. I can't think of anything else." And who wouldn't feel that way? Wouldn't you want to know as soon as possible this was cancer and get treated immediately? But I can assure you, Cancer Care Ontario doesn't want this. So, in Ontario, these patients with these nodules are routinely followed by CT, which was the standard in the mid-90s, for a year or more before their PET-CT is even considered. Now, in advanced medical jurisdictions around the world, offering PET-CT, the PET-CT would have been the next test once the nodule was discovered. Now, these people are fully aware of the stress their forced standards of care cause for patients, and not infrequently the delay in diagnosis can actually be fatal. But this is not their concern. Their mandate, remember, is to discredit, delay, and block PET, and no medical group on the planet has done a better job. Now, they admit that how they assess PET is not based on science whatsoever, and they have not challenged the statement of Professor Hicks from Australia that decisions on PET are based on an egregious and political agenda. So, my question to Cancer Care Ontario and the senior executives and Dr. Dobranowski is this. Why do you knowingly and therefore deliberately maximize the physical and emotional stress for these patients, knowing that such delays in diagnosis may decrease the patient's chances of survival? And thus, by conclusion, if you are diagnosed with a lung nodule, you should leave Ontario immediately. Thanks for listening.